We're going to talk now about Graves' disease. First, in this video, we're going to talk about the pathophysiology of Graves' disease. So, Graves' disease is a type 2 hypersensitivity reaction. We have an antibody against the TSH receptor. This is the TSH receptor in the thyroid gland, and this antibody activates this TSH receptor, and so the gland produces a lot of T4 and T3. So the patient is going to have hyperthyroidism. Remember all these signs of hyperthyroidism: increasing glucose, sweating, intolerance to the heat, diarrhea, disturbance in the sleep, sometimes osteoporosis and hypercalcemia, onycholysis, that the nail bed is desprending, many things. Next, the patient will have specific signs that are not only the hyperthyroidism but specific signs of Graves' disease. These will be the pretibial myxedema, and the exophthalmopathy or ophthalmopathy. In both of these, the issue is that fibroblast has receptors to TSH, and so when the antibody binds, will activate the fibroblast. Now the fibroblast will secrete in the retroocular space, will secrete glycosaminoglycans, hydraulic glycosaminoglycans, that leads to osmotic swallowing of the muscle and muscle inflammation and increase in adipose tissue. Also, the T lymphocytes will be secreting tumor necrosis factor alpha and interferon gamma, that leads to the activation of the fibroblast. This plus remember that the muscle of the eyes that elevates the lid is the palpebral levator ocular muscle. If this muscle has beta adrenergic receptors, so remember that the increase in T4 increases the receptors of the beta receptors. So there will be more activation of the muscle and will contract the muscle, and so the patient has a retraction of the eyelid. So it is not only that there is protrusion of the ocular eye, also there is retraction of the eyelid. And pretibial myxedema is the same. There are also fibroblasts with the TSH receptor that got activated, and now what's happening in the retroorbital space is happening in the tissue, in pretibial tissue. This is called pretibial myxedema. Next, the patient can have tachyarrhythmias. Remember, atrial fibrillation would be very common. The treatment will usually be first. Well, I thought that we were going only to talk about pathophysiology, but I suppose I'll continue with treatment. The treatment will begin with calming the symptoms. This will be achieved by beta blockers and the antithyroid medications that are propylturacil and metimazole. Usually we give metimazole. If don't, we give propylturacil, because propylturacil has more hepatotoxicity a lot than metimazole, even though both of them can produce a granulocytosis. Next, if the patient has a very large thyroid that is causing compression symptoms, or if the patient is in pregnancy, or it is a child, usually these are the indications for a thyroidectomy. Now, the indications for radioactive iodine treatment, this would be a unresponsive thyroid gland, that is, the patient is taking a lot of metimazole or propylturacil, and if the patient has increased size of the thyroid gland, could also be indications of radioactive iodine treatment. But remember that this increases the risk of worsening symptoms of ophthalmopathy. So if a patient has severe ophthalmopathy, we usually prefer to do the thyroidectomy, even though it's considered that radioactive treatment is the long-term treatment for Graves' disease. The incidence is increased in those that have the HLA-D3 and the 8 D8. Usually the hyperthyroidism is diagnosed in stress situation, like usually would be seen after pregnancy or something like that, and maybe the patient was undiagnosed. And histologically, what we will see will be diffused glandular enlargement, irregular enlargement with scalloped follicles. The follicles would look like scalloped here. They would not be round like this, would be like scalloped. And we will see tall cell follicular hyperplasia. So here the most important is to know how to diagnose. Remember, the specific symptom will be the ophthalmopathy and pretibial mixed edema. The treatment is beta blockers, antithyroid medications, and in some cases the thyroidectomy or radioactive iodine treatment.